So this is your time, so please feel free to raise your hand if you have a question while I'm speaking. Um, my plan was to go through, we'll start at the beginning with just some of the current treatment options that are available that many of you are probably quite familiar with and have used, but we'll just try to give some updates on those if there are any, and then talk about some of the studies that are ongoing now with new products for von Willebrand disease, which is exciting for us. And then I thought we'd talk about a few patient cases just to make it more real and see how we use those therapies and how we're trying to help make those decisions when we see you all in the office and you need to have surgery or you're having a baby. And then I was going to take a pause, make sure we don't have any other questions or points of discussion. And then if we need some more content, I have some things at the end about management of menses in general, like the hormonal side, not the um, hemostasis side as much. So that's our plan. And with all of these, I've really tried to focus on the women's health perspective. And when we talk about therapies, we kind of think of them in three different buckets. So, some of the therapies we give, our goal is to increase von Willebrand levels. Sometimes our goal is to replace the von Willebrand levels. So, we're giving the patient von Willebrand factor. And then we have other therapies, primarily antifibrinolytics that we'll talk about, that we really use for a variety of bleeding disorders. So they're considered more adjunctive therapies. And those come in really handy because I noticed a lot of people in the room have more than one reason to bleed, and that's not uncommon for us to see in clinic. So that's why we love agents like antifibrinolytics and some of the newer agents we'll talk about, because they're really addressing multiple areas within the hemostasis system. So first we'll talk about desmopressin, and this bottle is a blast from the past, right? Because we don't have stimate anymore. Most people, I think, will think of 2020 as the year of the COVID-19 pandemic. For hematologists, we'll also always remember it as the year that stimate went away, because that was also a challenging time for us. Um, Fortunately, we now have, I think, many of the major cities throughout the United States now have a compounding pharmacy who will make compounded DDAVP for patients. So if this is something that maybe you used in the past that you thought you didn't have access to anymore, definitely ask your hematologist about that. In Columbus, Ohio, for example, we have one pharmacy downtown that I was chatting with the group up front who knows Dr. Dunn, my colleague at Columbus, Ohio, and she's, as they know, a real go-getter. So she worked very quickly to try to work with a pharmacy in our city so that we could offer this to our patients. So what desmopressin does is it triggers the body so we have clotting factors in our blood. We also have clotting factors that are kind of stored in the vessels of the walls of your blood vessels, kind of waiting to see if they're needed. And so what desmopressin or DDAVP does is it triggers that release of the stored clotting factors that you had, specifically von Willebrand factor and factor VIII. But it also kind of helps to activate platelet function and some other things. So we use for patients with mild factor VIII deficiency. We also use it for patients with platelet function defects like platelet storage pool disorder. And we have also used it for patients with joint hypermobility. So it's really used in a variety of different ways. Um, there was a study done by Dr. Curlin at my institute a while back that showed that we struggle with patients with joint hypermobility because we don't have a good blood test to see what's going on. But we know from back in the old days when we used to do a bleeding time that patients who had joint hypermobility and long bleeding times, when we give you DDAVP, it shortens the bleeding time down to normal. This medication we typically give intravenously. You can give it subcutaneously, but we mainly do it IV or intranasally. And we already talked about all of the different ways that it can be helpful. I think The other nice thing about DDAVP is the effects last for about 24 hours. So that's really helpful with surgeries and things where you can kind of do it and then you have 24 hours before you might need to do something else. Um, I'm sure any of you who have used DDAVP can speak freely about the side effects. It's not always somebody is shaking their head. Um, Sometimes people will be like, never again. So there are some side effects that we see, and these include flushing, dizziness, headache, nausea. DDAVP also causes fluid retention. So it's important when patients are using DDAVP that they have to restrict how much fluid they're taking. So, for example, that can be problematic with our athletes. Maybe they want to use DDAVP before they play that sport, but on the other hand, you need to be able to drink fluids while you're doing a sport. So, working with that balance. It also makes it tricky to use during infant delivery because that they pump you full of fluids during infant delivery. So, we have to be cautious in that setting as well. So, um, I don't know if anybody here has done like a DDAVP challenge in clinic where they brought you in. And what we do is we measure the von Willebrand levels before we give the dose, and then we give the DDAVP, and then we'll measure it again at hour 1. And then at our site, we do hour 4 as well, so we can see what your peak is, and then make sure that peak is lasting for a long time, which is important, especially if somebody's going to be having major surgery, where we want to make sure that that whole time they're in the OR, that they're getting good coverage with that DDAVP. For our patients with platelet function defects or with joint hypermobility, we don't do labs pre and post the DDAVP usually, but I still always recommend to patients that they come into clinic to do that challenge with us. One, it's just another touch point with our nursing team to go over again the fluid restriction rules, to go over the side effects. And I also want to make sure that the patient tolerates DDAVP well. Some people get really bad flushing, a really bad headache, and they never want to receive the medication again. That's not something you want to find out 30 minutes before your surgery. So that's why the challenge is so important, even if we're not measuring labs. Yes. Right. So, so you're talking about on the slide here where it says tachyphylaxis, meaning that the medication is less effective over time. And that's exactly due to the reason you're saying there's only so much we have stored in our blood vessels. And so typically the rule of thumb for most patients is that you can use DDAVP 2 days in a row. Occasionally we'll use it a third day in a row, but typically we try to stick to 2 days in a row. So if you're having a surgical procedure that requires more longer coverage than that, you're absolutely right. The DDAVP may not be sufficient, and we may need to replace factor instead for somebody with von Willebrand or a factor deficiency. Um, that's the other reason why the challenge is so important, because for some patients, like there's a type of von Willebrand called 1C where they have very rapid clearance of the von Willebrand factor. So those patients may look great at hour 1, but then by hour 4 they're back down to where they were before. So that's the other thing that helps us know whether stimate is a good, or DDAVP is a good choice for that patient. And that's also why we use it for patients with type 1 and some of the milder type 2s. But if somebody has severe type 1 or one of the other more severe types, it also may not be a good choice. It's also the reason why it's not a great choice before using for heavy menses, for example, because most people's menses, especially if you have a bleeding disorder, do not last 1 to 3 days. So you're not going to get that coverage throughout. Yes.
I'm not gonna do it again, but, I was glad when it went away, when we started using about 16. But, as adults, should we be repeating these studies if this is my DED, we said in 19,
Hmm.
I don't know how they got records somehow from Germany. Now, that's when I saw mine was done. So like, is this something that should be repeated as an adult? Because like my levels have more leveled out. I mean, now I'm still bleeding like a mop,
Hmm.
severe. So is this something that should be like repeated throughout the lifetime? Medication that, your family.
Sure. So my approach is usually, do I think it's a medication that the patient is going to need? And I would say these days, most of my patients with von Willebrand do not need to use DDAVP because we're using other treatments for their heavy menses, or maybe we're going to use factor replacement for their surgery. So times when I use this are for, there's a variety of different situations. One of the most common ones is if nosebleeds is a particular problem for a patient, because this is helpful for nosebleeds. Because I also feel like if I'm going to ask you to pay for this medication, I want you to be using it. Another scenario may be maybe somebody doesn't live close to us and they're getting their wisdom teeth out, and it would be a pain for them to drive to Columbus, get factor, drive back out to their oral surgeon. So in that case, DDAVP may be a great way for them to get a procedure done locally with a care provider that they know well. I think the last reason that I commonly use it is if I have a patient who's going away to college and they're not going to be at a spot where they may have quick access to therapies. So I like this because it's something that they can keep in their dorm room and just have something on hand that would be useful. Yeah. Mhm. Sure. So I think, and actually your question reminded me, I missed part of your question, so I'll get back to that. But um, so for somebody who's pregnant, and we'll talk about that a little bit later, if you have von Willebrand, your von Willebrand levels should be checked in your third trimester. And that will help guide us as to whether you even need to have your factor levels increased during delivery, or are your levels already comfortably over 100 by the third trimester. Um, and then we'll talk about the different strategies. There are this this is a situation where if you got hematologists in a room, we could argue for a while about it. There are some hematologists who feel really comfortable with desmopressin during infant delivery, and they've had great success for it. I think my hesitation for a patient like you would be, one, again, I don't want you finding out right before you're supposed to deliver that you have intolerable side effects to DDAVP, because having a baby is already a pretty uncomfortable experience. So that would make me nervous. And also, if you're not, like, for example, one of my friends who's really comfortable using this, she's in a setting where, she's her patients are being delivered in the same building. Like, she knows those OB-GYNs really well. They have a long-standing relationship. She's comfortable that they know what they're doing with the fluid management. If you're delivering in a site where there's not that experience and collaboration between the two teams, then it makes me more nervous about DDAVP. But I'll get back to you. You had asked about rechecking doing a re-challenge. And I would say, yes, if somebody's tests are from 3 years of age, it's worth redoing for two reasons. One, von Willebrand levels go up when we're nervous, right? So if you're a 3-year-old who's going to have an IV placed, I think you're probably pretty nervous. So a lot of times when we bring young children in who clearly have von Willebrand and we bring them in for their DDAVP challenge, their pre-levels are normal because they're so stressed out about getting the IV that day. And von Willebrand levels also increase with age. So that's another reason why it's good to see what your baseline is and how much it improves afterwards. But again, I would only do that if you think there's a definite reason that you're going to be using this agent. Mm-hmm. Yeah. Excitement, exercise, being sick. Yes. Mhm. So people have already mentioned, and we've talked about when, okay, DDAVP is raising the levels you already have, but we also have von Willebrand concentrates that we can use that are giving back the von Willebrand levels that are needed. And we now have more options available than we used to. So for a while, we've had the plasma-derived von Willebrand products. We use Humate at where I work. Somebody mentioned Willate, that's another one, and that really will depend on where you receive your care. Um, the newer recombinant factor, where we always put the generic names on our slides and then nobody ever knows the generic names, but that's Von Vendi. And that is a recombinant factor. So that is a man-made factor. It's not a blood product like the plasma-derived ones are. So I think and for us in pediatrics, there's been a big update within the last year where Von Vendi is now has a approval from the FDA to use in pediatric patients. So that is really exciting for us. It's also expanded the use to adults with all types of von Willebrand disease. So definitely has hopefully increased the indications that we can get insurance approval for this agent. Um, you can see that, so the half-life is how long a medication lasts. So what that means for the human von Willebrand products is the half-life is about 12 hours, meaning I'm making these numbers up, but let's say your level of that medication was 100. After 12 hours, you would expect it to be 50. After another 12 hours, you would expect it to be 25. Like that's how the medication is going down in your body. And we talk about that with all the different medications we use, whether it's antibiotics or factor replacement. What's the half-life? Recombinant factor has a longer half-life, which means we don't have to dose it as frequently often. Um, for some patients, it is important to them that it's not a blood product. That's something that makes it a more appealing choice to them. I think the other big difference between these two products is that the recombinant form, or von Vendi, only contains von Willebrand factor. That's different from Humate and Willate, which are products that have von Willebrand factor and factor VIII in it. So that can be important to us for a few reasons when we're trying to decide what to do. So if I have a patient with von Willebrand disease who also has low factor VIII levels, which is not uncommon, then von Vendi may not be the best choice for that patient, or we may need to also give factor VIII if we're giving von Vendi. So I would usually lean towards using a product that includes both factor VIII and von Willebrand, so we're only having to give you one medication. Yes.
Feel free to answer this later and cover it, or if it's like a separate conversation. It's something I've really been wanting to the difference of diagnosis between von Willebrand with low factor VIII and hemophilia A with low? I've heard it both ways, and I'm wondering why there's a clinical reason as to why one might be diagnosed with hemophilia A with low von Willebrand's, then the next person might be diagnosed with von Willebrand's disease with low factor VIII, but if their levels are under factor VIII, it can be a separate conversation if it's not suited for here, you think, but that's just something kind of touched on it, and it's been taking it away.
I'd be curious to see your thoughts too, John. I see that in a few different ways. Sometimes I think sometimes when I'm presented with that scenario, it's because there's been a misunderstanding from the person who maybe originally ordered the test. So some primary care doctors, for example, may not know that factor VIII can be low in patients with von Willebrand disease. So they've told that patient they have two different things when actually it's all the same thing. It's all part of their von Willebrand disease. But there are also families I've seen where we know that they have hemophilia A due to genetic testing, for example, but then there are members of that family who also have low von Willebrand levels. Having low von Willebrand levels is pretty common. So in that scenario, then you do have a patient who may have mild factor VIII deficiency and also has von Willebrand disease. Does that make sense? Would you add anything? Mhm. And I think it's also hard, it's how lab results are communicated. So, for example, maybe what the genetic counselor was saying is that you don't have a genetic mutation consistent with von Willebrand disease, but just like Dr. Davis is saying, most patients with especially type 1 von Willebrand disease, we don't have a gene that we point to for those yet. So I almost wonder if that's what they were saying. Right. Right. So maybe she was talking specifically about genetics. Yes. I'm not sure of the connection between platelet storage pool and von Willebrand. Mm,
I was just curious. I looked at that in everybody.
right. And we're also doing more, especially for people with who maybe have a laboratory diagnosis that would suggest a mild bleeding disorder, but they have more clinically severe bleeding symptoms. I think we're doing a better job in hematology of making sure that there's not more than one thing going on. So that may be why they're going back and revisiting as well. Just like for my patients with hypermobility, even though we know that's a reason for bleeding, these things are not uncommon. So that we still test for von Willebrand and platelet function, and it's not unusual to have more than one thing. So I think that's the link. There was one more point I wanted to make about factor. Oh, just as it's possible for somebody with von Willebrand to have low factor VIII, some patients, especially with type 1 von Willebrand, may have completely normal factor VIII levels. Factor VIII levels can also be elevated if somebody has an inflammatory disease. Maybe they also have rheumatoid arthritis or lupus, or some patients with obesity may have an elevated factor VIII level. So that's something else I take into account when I'm deciding which product to use for a patient. So if I have a patient with low von Willebrand but a high factor VIII level, that then the von Vendi is very appealing to me because I don't want to shift their factor VIII so high up that I'm placing them at risk for a blood clot. So that's when this targeted von Willebrand factor can be helpful as well. So we're always, our job as hematologists is always to try to balance bleeding and clotting. And having having these two families available now helps us do that better, I think. We've mentioned antifibrinolytics. So these are, there are two medications that we use. One is called tranexamic acid and one is called aminocaproic acid. Um, they work the same way. They are both, as the name suggests, fibrinolysis is when our body is breaking down the clots that we naturally form. So if you think about if you have a cut and it's bleeding, your body makes a clot to stop that bleeding. And then over time, that clot will naturally break down. What the antifibrinolytics are doing is trying to slow the natural breakdown of that clot. We can use this medication IV, which we frequently do right before a procedure or before an infant delivery, and we can also give it by mouth. The tranexamic acid is only available as pills, and they're quite large pills, so that can be a barrier, especially in the pediatric world, and they're dosed every 8 hours. The aminocaproic acid is available as a pill. It's also available as a liquid, which is nice. I think the downsides are that, at least in Ohio, it's not a favorite among insurance companies, so it can be prohibitively expensive for our patients. We can also, it also has to be dosed every 6 hours, which is, I think, really challenging for any patient, any parent trying to do that regimen. Um, your pharmacist will tell you that you can't cut tranexamic acid in half or that you can't crush tranexamic acid, but there have been studies done showing that the medication is still effective. So what we will do is if we have a patient who can't swallow that pill, but their insurance will not cover aminocaproic acid, or Amicar is the brand name for that, we will have them crush tranexamic acid into applesauce or something to try to deliver it that way. The nice thing, oh, go ahead.
Like my hematologist, but I've also I don't have a protein that all I have in terms of my concern is if I come in, I just
We don't think so because it's still absorbed through the stomach. I think in general, you're making a good point that the antifibrinolytics, I think, are best used to prevent a bleed, like during surgery, or they are used for more long-term bleeding sounds like a strange word, but for menstrual bleeding where you have that sustained, thank you. Um, and for nosebleeds, you're right. It's often not very helpful for that nosebleed in the moment. So I tend to for the acute nosebleed, I'm more likely to recommend desmopressin if the patient tolerates it, or using Afrin or something like that that will stop it in the moment. But then what tranexamic acid is helpful for is some patients with bleeding disorders, if they get one nosebleed, they know they're really likely to get another one later that day or the next day. And so that's why I have them also take the tranexamic acid, because what that's doing is trying to minimize those nosebleeds that are left to come. Because a lot of patients, they'll have like a bunch over 2 days and then they won't have another one for several weeks. I have had, so those are most patients I will say don't have side effects. That's what's great about these agents. The ones that we do see are the abdominal upset and the headache. And in both cases, as soon as they stop taking it, those side effects will go away. So I've only had a few patients that have had abdominal pain. And I would say for some of those, we did try the other one and it was helpful. So I think it's worth trying. They did not have the same side effect with it, but that's like a small number of patients. Yeah, absolutely. No, you might be more sensitive to it. Mhm. It kind of soaks into it. Yeah. Nice. Yes. Yeah. No, that's a good point. And some programs will allow like one free dose. That's really helpful for our patients who may never need to use it, but we're able to have that at home just in case they need it. Really good point. So these medications, and I said from the hemophilia community, because these are medications that were initially developed for hemophilia, have been studied in that patient population, and are then coming over to other bleeding disorders. So we'll talk about them in relationship to von Willebrand disease here. So emicizumab, the brand name of emicizumab is Hemlibra. And this is a medication that has really changed the entire landscape of treatment in hemophilia. And so this is called a medicine that mimics factor VIII. So instead of giving a patient factor VIII, what this medication does is it almost like skips the need to have factor VIII in the clotting cascade. It skips a step to go down to forming the clot. So this is a subcutaneous injection. The dosing regimens vary by study and by patient, but it's given every 1 to 4 weeks. So you can see how for patients with severe hemophilia who were used to having to infuse factors several times a week, how this has been a big game changer in that field. They're starting to study this medication in severe von Willebrand disease, like type 3. But I think that's probably where it will stay. As we'll talk about some of these other newer agents, I think make more sense. Patients with severe types of von Willebrand disease is, I'm not even going to try to say the long name of this, but Altuviiio is the brand name of this. And this is a medication that is a kind of a super long half-life medication. So it's able to be given as a once weekly infusion, which, may cause your eyebrows to raise. But again, remember that these medications were developed for patients who were receiving multiple doses of factor per week. So again, that's specifically limited to the type 3 primarily. Yes.
Clotting factor backup for really rare out of
Yes. So these are medications that I think are exciting because they're being initially studied in von Willebrand disease. And I think, for somebody like me, where most of my patients have von Willebrand disease, it's exciting to see, all attention being paid to this patient community. Um, so this is a medication that's still under study. It's called B2-200 right now. And what this does is it's a medication that binds to the von Willebrand factor and we talked before about how slowing down the clearance of our clotting factors can be helpful. And that's what this does. It slows down the clearance of von Willebrand and extends the half-life of factor 8. And so this was initially studied in factor 8 deficiency and type 2B von Willebrand disease. And so that was exciting to see von Willebrand patients first off. And I just have this at the bottom here because you can see that these medications are being developed to target different areas of the von Willebrand protein. Von Willebrand protein is one of the largest proteins we have in our body. It's very complex, many different pieces. So this is a medication that's targeting right in the middle. This next medication is called HMB-002, and it is an antibody which binds to the CK domain of von Willebrand factor. And you can see in the picture that CK is at the very end of the protein there. So this is a medication that's going to slow down the breakdown of von Willebrand factor, so it increases our von Willebrand levels. So again, this is an exciting option for patients who, current therapies are not working, but we want to do something that doesn't require frequent dosing. So right now the studies are looking at subcutaneous dosing every 1, 2 to 3 weeks. There's an ongoing study of patients with von Willebrand type 1, which is exciting to see. Correct. Correct. Yep. hmm Absolutely. So I think I'm sure you see them in other places as well through newsletters, but clinicaltrials.gov is a website from the government that's really helpful for all audiences, us as physicians and also as patients, and it has a nice search feature where you can type in the disease that you have and see what studies are open in that area. And you can even see what sites have that study open. And then the last one I wanted to talk about here is called VGA 039. So this is going to be exciting because right now it's being studied in patients with von Willebrand disease, but I think it's going to be something that's applicable to patients with other types of bleeding disorders as well. So we're really excited about agents such as this in hematology. So we talked before about how in hematology we're always trying to balance bleeding and clotting. And when we have a patient with a bleeding disorder, regardless of the type of bleeding disorder, their balance is shifted more towards the bleeding side than the clotting side. When I'm teaching medical students about the clotting cascade, I talk a lot about how we learn in government about checks and balances, and that's what we have in the clotting system too. So Protein S is a protein that our liver makes that's a natural blood thinner. So that's part of our clotting system that is helping to prevent blood clots. But what it does is if we're acting against protein S, that helps to rebalance that bleeding and clotting for a patient with a bleeding disorder. So that's why, similar to antifibrinolytics, as Dr. Davis mentioned earlier, this is something that I think eventually will be helpful and hopefully studied in multiple types of bleeding disorders. This phase 1/2 study was presented at our annual American Society of Hematology meeting a few months ago. And what was also, so it was only in 11 patients, but it had promising results. And what was exciting to me as a practitioner was to see patients with type 1 von Willebrand disease in a study. Early days like this. And it was also exciting for me because this study is open to adolescents. So there were, even in the very early phases, a 15-year-old in the study, which is just great to see because sometimes we have to wait so long for treatments to get to the pediatric side. So those are kind of the things that are coming down the pipe, and I think there's a lot of excitement in the pharmaceutical industry about these types of agents. So I expect to see more options for patients with bleeding disorders. Um, I think we always talk about how so much attention has been paid to men with severe hemophilia, right? And for so long, the industry was focused on that. And I really think that now that care has improved a lot in that patient population, it gives us an opportunity to benefit from the pharmaceutical industry, kind of looking for new places where they can make a difference. Yes. I also wanted to make sure that everybody in the room I'm actually curious from a show of hands, is anybody familiar with this document, the ASH ISTH? It's a long bunch of letters. Yes. So everybody should be familiar with this. This was a great collaboration led by the American Society of Hematology, but also included ISTH, which is our International Thrombosis Hemostasis Society, the National Hemophilia Foundation, which, as you know, has changed its name since that time, and then the World Federation of Hemophilia. And they came out with guidelines. One set is for the diagnosis of von Willebrand disease, and another guideline that we'll talk about is for recommendations. And if you go to the ASH website is hematology.org. And if you go to that website or if you Google these recommendations, you'll see lots of patient facing resources for these recommendations that can be really helpful. We're only going to touch on a few of them today in the context of some patient cases, but they have recommendations on surgery, on heavy menses, on infant delivery, on the use of antiplatelet agents for older adults with von Willebrand disease. So just a lot of good information there. So we're going to talk about a few patient cases. So our first case here is a 16-year-old female with type 1 von Willebrand disease, and her baseline levels are in the 30s. And she has easy bruising, childhood nosebleeds, which have now gotten better in adolescence. And she has heavy menses, which are well controlled on an oral contraceptive pill. So she's in clinic today for her annual hematology visit, and she's actually doing really well. She doesn't have any concerns. But just before she's about to leave, she mentions that she's getting her wisdom teeth extracted this summer. So this is definitely something that we want to be involved with as hematologists. And I think sometimes this gets lost in the shuffle. When you're having a surgery at the hospital, the anesthesiologist is going to see in your chart that you have von Willebrand disease, and that will hopefully trigger them to call us, make sure that we're involved, that we have a written plan in place for your procedure. The majority of our patients' dental procedures are happening out in the community. So it puts a little more of the onus on you to make sure that your oral surgeon and your hematologist are both aware that this is happening and that they're working together to come up with a plan. One of my least favorite things as a hematologist is when my patient's surgery or procedure is canceled because somebody has realized right before they get wheeled into the room or come back from the waiting room that they have von Willebrand disease. So everybody's taken off work, off school. Like that's just not a good experience for anybody. So, as I mentioned, these guidelines include some specific recommendations regarding surgery. So, having your wisdom teeth out would be considered a minor surgery. A major surgery, um, the goal for somebody with a major surgery is that we're trying to keep the factor VIII and von Willebrand levels over 50 for at least 3 days after the surgery. So how we do that is going to depend a lot on what your baseline levels are, what type of surgery you're having, whether you're going to be able to eat or drink after the surgery. Those are all the things that we consider when we make a surgery plan. For something like wisdom teeth, again, that's a minor surgery. So the panel suggests that for patients whose baseline levels are under 30, so that would certainly be patients with type 3, some patients with type 2, patients with severe type 1, we do want to increase your factor levels for a few days in order to undergo that procedure. So we're usually using a dose of factor beforehand. Maybe we'd have you come into clinic to do that and then go to the oral surgeon, or if patients are not doing it at home. And then we're also going to use an antifibrinolytic. As you mentioned, antifibrinolytics are great, especially for oral bleeding. And so we would be using both. For a patient with type 1 whose baseline levels are over 30, which is most patients with type 1, we may only use tranexamic acid alone for wisdom teeth extraction. And I would say that since COVID and since Stimate went away, I have been doing that a lot more of just using an antifibrinolytic during wisdom teeth as opposed to DDAVP plus an antifibrinolytic. And that has been working really well. Um, so I think that if anybody have questions about, there's a lot on this slide. So I think that what you want to make sure your doctors are considering is whether this is a major surgery, whether this is a minor surgery. Is this a situation where we need to get factor levels up just before the procedure? Do we need to have them continue to be up for a few days, or can we just use an antifibrinolytic alone? Um, you also want to make sure that you have your antifibrinolytic in hand before you have the procedure. So I always make sure my patient has a prescription, that they've picked it up, that there aren't any prior auth issues, so that people aren't scrambling to get to CVS or Walgreens, right after you've just had a tooth pulled. That's not any fun. So this is what I was talking about before. We call them individualized plans because they really are designed for each patient. And that's why we're annoying. And every time you have a procedure, we say we have to make a new plan for you because it's individualized both to you and also to what the procedure is that's happening. And so it makes a difference on what we're using and how many days. And I will sometimes, if my patient is having a procedure that I'm not familiar with, I will call the surgeon and say, you're doing this with my patient. How many days do you expect them to be at risk for bleeding? That's very helpful for me to know how long my plan needs to last for. We talked about balancing bleeding and clotting. So as patients get older, we worry more about the risk of thrombosis, especially if they are going to be having maybe an orthopedic procedure and they're not going to be moving around a lot after that. So then we have to take into account their baseline levels, any other risks for thrombosis that you might have, your mobility after the surgery, all sorts of things. So sometimes our patients understandably get confused because they're like, wait, so I'm getting a medication before surgery to prevent bleeding, and then I'm getting a medication after surgery to prevent a blood clot. And we say, yes. That is what we're doing because before the procedure for you, we are most worried about bleeding. After the procedure for you, because of maybe your age or other risk factors that you have for blood clots, we want to make sure that we're not causing a blood clot because patients with bleeding disorders can develop a blood clot. It's not a 100% protective against that. Hmm. Yes. Hmm. Right. And that raises an important point that we often modify what's happening after surgery. So in your example, you received half the dose that a patient without a bleeding disorder would. Another example of that is sometimes, particularly for orthopedic surgeries, they may like to use aspirin as their blood clot preventer after surgery. I don't want my patient to receive aspirin because aspirin lasts in your system for 7 days. And if my patient has a bleeding problem, now I'm stuck with this aspirin on board. So we will work with the orthopedics or cardiothoracic surgeons and say, yes, we can do clot prevention, but we want to do it this way with shorter acting agents so that if there is a bleeding problem, it's something that we can turn off for our patient right away. So we have to be involved on the front end and on the back end. We also always remind surgeons, especially for oral surgery, other procedures, there are also local things that they can do to help prevent bleeding, which is always helpful. So, for example, tranexamic acid now comes in an inhaled form that they can use in the operating room. So, my ENT colleague may use that for my patient who's having a tonsillectomy, for example, because then you're getting it like right where you want it to be. No, it's like a mist. Yes. So the patient's asleep when they're doing it, but yeah, it's like almost like getting a breathing treatment, like if you have asthma, but it has tranexamic acid in it. Yes, I don't know if I've never seen it used in the, because usually they will do packing or something if somebody's in the ER, but that's a good point. Yeah. So for this patient, so what we would have this patient do is, again, they're usually having their wisdom teeth done by their local oral surgeon, which is great. Um, and we will recommend that she take tranexamic acid by mouth. And we always tell you to do it with a very small sip of water because the anesthesiologist will want you to be nothing by mouth. And so oftentimes patients will like do this before they leave the house or when they're in the parking lot before they walk in. And then we have them continue it every 8 hours for 2 to 3 days after the wisdom teeth. For my patients with hypermobility, I'm going to lean more towards that full 3 days because you may have slower wound healing than somebody who doesn't have joint hypermobility. This may also be an example of maybe you can usually swallow tranexamic acid pills, but maybe right after all of your wisdom teeth have been removed, it doesn't feel so good to do that. So that may be also a time where you want to crush it, even if you don't normally have to. Okay. So the next patient we're going to talk about, this is a 29-year-old patient who is coming to us for preconception counseling. She has type 1 von Willebrand disease and she's never been pregnant. She was diagnosed when she was a teenager when she presented with heavy menses and she's been doing great on her oral contraceptive pill. But she is anxious about having to stop her birth control pill in order to try to get pregnant because she doesn't want to revisit the past of heavy menstrual bleeding. And we don't, as somebody else mentioned, we don't have her pediatric lab test results available for review. So one important point here is that one of my gynecology friends always tells the story of a patient with von Willebrand disease who came to see her because she could not get pregnant. She had been trying for 2 or 3 years. And when they reviewed the medication list, Dr. James, my friend, said, "You're on a birth control pill." And the patient said, well, that's not a birth control pill. That's for my von Willebrand disease. So making the point that, we call we're careful to call these medications hormonal therapies. That's the word I use in the office, because for most of my patients, we're not using it for birth control. Maybe they're adolescents. And, but just keeping in mind that you cannot get pregnant when you're on a birth control pill. So that was an easy solution for that particular patient's. So this can be a anxious time for patients because they've been doing really well for years. Now they want to explore a new journey, but they're nervous about coming off of their medications. So, and I think there's an assumption that we don't have anything to offer them, that they're just going to have to kind of grin and bear it until they achieve pregnancy, and that is not the case. Antifibrinolytics are a great choice to manage heavy menses when we don't want to use hormones. Desmopressin for patients who tolerate it is another option. And this may be a time when maybe a patient never needed to use factor replacement because hormonal therapies worked great for their heavy menses, but maybe this is a time in life where we do need to do some factor replacement. So it's definitely not a grin and bear it situation. In Definitely a good time to check in with your hematologist beforehand so that we can have a plan in place if menses start to become heavy. This is also why I'm excited for these new therapies that I mentioned that are coming down the pipeline, because I think these will also be great non-hormonal options to have us more things in our toolkit that we can offer patients who can't use hormones. Right. I think another misperception that I hear in the office is that somebody has been told that they may not be able to have children, or that they're going to have a harder time getting pregnant because they have a bleeding disorder. And there's not an association between fertility and bleeding disorders. So that's another misperception that we see. Sometimes I think this is getting better now that we have electronic medical records and things like Care Everywhere, where we can see labs that were done at other hospitals, but that's definitely not a perfect system. And there are still cases where adult hematologists may not have access to your pediatric records, especially if you've moved to a different state. So I think whenever we're meeting a new patient, we always want to revisit the diagnosis and see where those baseline levels are. As I mentioned earlier, von Willebrand levels increase with age, so that's another reason to recheck if it's been a while. The patient may also have developed an inflammatory condition that may be increasing their von Willebrand levels. For this patient, she is on estrogen when we're meeting her. There's estrogen in her birth control pill. So we're not going to want to test her that day. We're going to want to wait a few weeks to test her. Ideally, at least 4 weeks. It takes about 3 months for a birth control pill to get completely out of your system. But after 4 weeks, those coagulation factors are pretty much close to baseline. But you want to make sure she follows through with this, because what often happens is we never see this patient again until they're pregnant and now they need hematology again. But von Willebrand levels also rise during pregnancy, so that's not a good time to get a baseline either. So you want to get them in 4 weeks. So, talking a little bit about von Willebrand treatments during pregnancy. Once a patient is pregnant, um, desmopressin and antifibrinolytics are not contraindicated, but we usually, as with all medications when you're pregnant, we try to limit the use of them whenever possible. Certainly, we use these medications a lot very close to the time of delivery, but especially during those early stages of pregnancy when all of the organs are forming, we try to limit the use of medications. Um, for desmopressin, we already talked about the issue with fluid retention and how that will be more of an issue during pregnancy. We also have to consider that desmopressin can increase blood pressure. So certainly if a patient is having hypertension due to pregnancy or having preeclampsia, we definitely don't want to use desmopressin in that patient. We don't have great studies on antifibrinolytics, but we also don't have any evidence that there would be any harm to the fetus from these medications. So for this patient, she returns 4 weeks later and has testing and done, and you confirm that she does have type 1 von Willebrand disease. She's happy to hear that she is not at increased risk of infertility. She's happy to hear that we have treatments for her heavy menses should they occur, and also some treatment strategies to prevent postpartum bleeding. Um, we give a script for tranexamic acid so that she already has that at home and can start it right away if she's experiencing heavy menses. And when she comes for her return visit, she does report that once those OCPs got out of her system, she did have a much heavier period, but that the tranexamic acid worked well to make that a manageable menses for her. And I think I have one more patient I want to do, so we have time for that. So this is our last patient is a patient who is now pregnant, and she's coming to hematology because there's a family history of von Willebrand disease that was recently diagnosed in her sister. So the patient we are seeing does not currently have a diagnosis of von Willebrand disease. She does, though, have a personal history of heavy menses, which she had never thought much of because they were just like her sisters. But now looking back, she thinks they were probably heavy, but they were well controlled with oral contraceptives. She's only had one procedure in the past, which was wisdom teeth extraction. And she remembers that they had to go back and get more gauze because they ran out of gauze at home. But again, they didn't know that that was unusual. So she asks about delivery planning given this new information. And specifically, she's very interested in getting an epidural and wants to make sure that that won't be an issue. So you check labs today, and her von Willebrand levels are in the 50s. Her factor VIII is in the 60s, and these are, listed as normal in the chart, right? Those are not going to be red levels. They're above 50, so they're normal. But what is a normal von Willebrand level during pregnancy? Um, so it's important to remember that the laboratory range is not taking into account that natural rise in von Willebrand levels that occur during pregnancy. So we know that above 50 is normal in the general population and should um, lead to normal hemostasis. But what we don't know is what is a normal von Willebrand level in the third trimester that leads to normal hemostasis during that infant delivery. So, you know, thank goodness that this patient, this is all happening in a hematology office. If this visit had all happened at the OB-GYN and they had checked those levels and they came back as normal, that might have been the end of the story for that patient. She might have been told, you don't have von Willebrand disease like your sister. You don't need anything special during the delivery. And that would have been the wrong answer for that patient, I think. Um, so in our patients with von Willebrand, as we mentioned earlier, we always check levels during the third trimester. Um, most of my patients are adolescents who are more prone to pregnancy complications. So I always check and are more prone to preterm deliveries. So I always check a little on the early side. I like to get that done at 32 to 34 weeks. One, just in case baby decides to come early, or two, gives me a little time to get that plan in writing, make sure the plans with the gynecologist, everybody's seen it, gives us our time to do our work. So regardless of what your von Willebrand levels are in the third trimester, some hematology support is recommended for all patients with von Willebrand disease at the time of delivery. Um, and again, that level that we're aiming for continues to be a bit elusive, but it's definitely changed even during the time that I've been in practice. And aiming for 50 is no longer standard. We're always aiming for levels over 100. There was a recent study presented at at our hematology meeting in 2024, suggesting in women with hemophilia, suggesting that 120 should even be a better level of what we're aiming for. So we definitely want to get that level up there. So We also recommend that women with low von Willebrand levels should be delivering in a specialized center if at all possible. I always tell my patients that if their insurance allows it, I'd much rather them have their baby in the academic hospital. Yes, it's not fancy. There's not going to be massages or a lobster dinner after the delivery, but there's going to be a hematologist somewhere in that building who will be able to help if there's a problem. There's a neonatologist right there to help if there's a problem with the baby. So if possible, I always think it's nice for our patients to be able to deliver in a large center. It's not always possible, and in that case, I'm going to just make extra sure that their office has received our plan, that they don't have any questions about it, that all of the medications we're suggesting are available. So for example, one of my patients who delivered last week, they didn't have it at the hospital where she was delivering it, but they had a sister hospital across town that did, and they brought it over to her. So we just make sure there's more communications. If your levels are over 100 during that third trimester, then we're not going to need to replace your factor level during delivery, and we'll use antifibrinolytics alone.
Like I've not had a child, but my two, so one of them when everything like a lot of restrictions. But so how not worrying about your level dropping for I have a lot more right after
Mhm.
like
Sure. So again, our plan's going to depend on what that patient's baseline level is. But the levels are going to start to drop with if they're up for about a few days after delivery, and then they'll start to immediately drop down. And about 12 weeks after delivery, they will be back to baseline. So most of my patients have type 1. Most of them are going to have levels that get pretty high during that third trimester. So for most patients, using the antifibrinolytics alone after delivery are going to be able to manage their bleeding after delivery. And we just automatically have that at home for them. We automatically have them take it. We don't like wait to see if there's a problem because we know that their levels will drop. If we have a patient that we think their levels are going to get quite low, that may be a patient where we have a factor replacement plan ready to go or a as needed factor dose at home. Like again, depending on the levels, the baseline levels are helpful to us, and knowing what that patient's need for factor in the past has been has is helpful for us.
I one sister hemorrhage right on the Mediterranean because she did have no OB-GYN, but in the hospital. And she almost died. This was like 10 years ago. And then her second pregnancy, well, they had a factor on hand, and she hemorrhaged it. My twin sister, she hers wasn't much bleeding, but then she whatever the worst tearing and luckily they had for that. They just always have a plan to have factor in case needed. Um,
Yeah.
maybe not.
Absolutely. And for a patient that we know we're giving factor to at the delivery, let's say their levels did not get up to 100 in the third trimester, or they have a more severe type of von Willebrand, we're checking that patient's factor level every day in the hospital to help guide, because we know it's changing. And so we're using that to help guide therapy, and knowing what that level is before the patient goes home also helps us know, well, are they still going to need factor at home? How quickly do we need to get that or make a plan for them to come to clinic? Mhm.
So they were not considered. With Jessica, we had they had her receiving factor or make the minute she delivered.
Yeah, they get big. Mhm.
They went ahead and
Right. Yes. So definitely for patients with more severe disease, we're handling the delivery more like a surgery, where we're having a prescribed number of days afterwards. This slide is just showing what we were talking about in a more pictorial, so that making it clear that for patients with severe type 2, type 3, like those patients, we know they're going to need factor. We know they need to be in a specialized hospital to deliver. For the majority of patients who have type 1, a lot of our planning comes down to that third trimester level. If they're less than 80, we know we're going to need to give factor. If they're over 100, we can usually just give antifibrinolytics. And if they're kind of in the middle, we prefer to give factor if we can at the location where they're delivering. And then, just as we've talked about, we're going to redose that factor as needed. Um, Tranexamic acid, I always prescribe a 14-day supply to have at home. And I tell the patient that they can, I, I think that the fact that you still bleed when you go home from the hospital after having a baby is something that's not talked about like in general for women. And so I think that just understanding that that is what happens and that that bleeding may be heavier in somebody with a bleeding disorder is really important. I prescribe it for 14 days. I tell the patient if it's been 24 hours and you're not bleeding or it's just spotting, you can stop it early. They don't have to take the whole 14 days. Um, but because those levels are dropping in those first 1 to 3 weeks, it's really important. We talked earlier about how somebody maybe didn't recognize their periods were heavy because they were just like their sisters. I definitely have had several times where I ask the mom of the patient I'm seeing, I've learned that I can't just say, did you have excessive postpartum bleeding? I need to say, did you bleed for more than 2 weeks after any of your infant deliveries? And I'm shocked by, now that I've learned to rephrase it, how many people didn't realize that was unusual. They're like, oh, I always bled for a month. Is that weird? So it's just, again, we're not educated on what's normal. Um, Usually, people are told to come back at 6 weeks for a postpartum visit. For our patients with bleeding disorders, we always recommend a 2 week postpartum visit. I know it's hard to get out of the house when you have a little one, but it's really important, one, to check in on whether your postpartum bleeding has stopped. And if it hasn't, what are we going to do about that? And also because you're more at risk for iron deficiency anemia, and making sure that that didn't develop or worsen with the infant delivery. Um, all of the medications that we use are safe to use during breastfeeding. So that's another really important point. So last slide, our patient. So yes, her levels are in the 50s, which are normal, but we explained that actually for somebody in the second trimester, levels of 50s makes us think that she probably does have von Willebrand disease. We repeat her levels in the third trimester and they've increased as we've expected, but they're still less than 100. So we do give von Willebrand concentrate to this patient during the delivery, and then she used tranexamic acid afterwards. And then she comes back to see you at 5 months postpartum. We do the repeat testing and confirm that she does clearly have type 1 von Willebrand disease. So luckily, all of our stories here have all had happy endings, but I know sometimes they can have frustrating or scary endings as well, as some of you have expressed with your stories. Yes. I think we have 1 or 2 minutes for more questions if there are any. I'm also gonna just plant myself here during the break with a cup of water. So if there's something that you wanted to ask me in private, that's totally fine as well. But yes. I think that I think OBGYNs are doing a better job. I think education has improved in that field. I think they're doing a much better job of thinking about bleeding disorders when women present with heavy menstrual bleeding. Um, I do think like the fact that they took a family history in this case and elicited the diagnosis of von Willebrand disease is also helpful. But I think where the sticking point is that the testing is complicated and they're not experts in what tests to order and how to interpret that testing. The other thing about the Foundation for Women and Girls with Blood Disorders that I'll mention, their website also has a map of the clinics in their network, and those clinics all have a hematologist and a reproductive care provider as part of the clinic. So that's a good place to see if maybe you are within distance of being able to see a gynecologist who particularly specializes in bleeding disorders.
Thank you, Dr.
Oh, you're welcome.